Welcome, MedScenes Medics. Today, we're doing a rapid revision of the three major causes of nephrotic syndrome using a simple framework that will help you recognize them quickly in exams and remember the key features that distinguish them. So, grab your coffee, settle in, and let's get started.
So, what are the three main causes of nephrotic syndrome? Minimal change disease, or MCD, focal segmental glomerulosclerosis, FSGS, and membranous glomerulonephritis, MGN. Although these diseases produce nephrotic syndrome, they differ in four key ways. When you're answering examination questions, ask yourself, who gets the disease? What causes it? What do the kidney biopsies show? How does it respond to treatment? These four questions are all you need to distinguish the three major causes of nephrotic syndrome. So let's start with the first question. Your first clue is the patient's age. MCD is the most common cause of nephrotic syndrome in children, and most childhood cases are idiopathic, meaning no identifiable cause is found. FSGS can occur at any age, so it should always remain in your differential diagnosis. MGN primarily affects adults, with the highest incidence between 40 and 70 years of age. For examinations, remember this simple rule: child, MCD; adult, 40 to 70 years, MGN; and any age, consider FSGS. Age won't make the diagnosis, but it's an excellent place to start. Next, we will look at what causes each disease. Although all three diseases cause nephrotic syndrome, they damage the glomerular filtration barrier in different ways. MCD is a functional podocyte disorder, causing diffuse foot process effacement with little permanent structural damage. FSGS also begins with podocyte injury, but the damage progresses to permanent glomerular scarring with a poorer prognosis and variable steroid response. MGN is an immune complex mediated disease. Subepithelial immune complex deposits activate complement, injure podocytes, and disrupt the filtration barrier. For examinations, remember, MCD is a functional podocyte injury. FSGS is podocyte loss with glomerular scarring, and MGN is subepithelial immune complex deposition. Let's see what the clinical presentation adds. Although all three diseases cause nephrotic syndrome, several clinical clues can help distinguish them. MCD typically presents with an abrupt onset, selective proteinuria, and little or no hematuria or hypertension. It also has an excellent response to corticosteroids. FSGS is more likely to present with hematuria, hypertension, and reduced kidney function, and responds less well to steroids. MGN usually presents in adults with non-selective proteinuria and relatively preserved kidney function early in the disease. The steroid response is also generally poor. For examinations, remember, MCD, abrupt onset, selective proteinuria, excellent steroid response. FSGS, hematuria, hypertension, reduced kidney function. And MGN, adult nephrotic syndrome with a poor steroid response. Clinical features narrow the diagnosis, but the kidney biopsy confirms it. The kidney biopsy is the most reliable way to distinguish these three diseases. On light microscopy, the differences are straightforward. MCD has essentially normal glomeruli. FSGS demonstrates focal segmental glomerulosclerosis. Remember, focal means some glomeruli are affected, and segmental means only part of each affected glomerulus is scarred. MGN demonstrates diffuse thickening of the glomerular capillary walls without significant hypercellularity. For examinations, remember this: MCD, normal light microscopy; FSGS, focal segmental sclerosis; MGN, diffuse capillary wall thickening; Light microscopy narrows the diagnosis, but the definitive clues come from immunofluorescence and electron microscopy. Immunofluorescence and electron microscopy provide the definitive pathological clues. On immunofluorescence, MCD is usually negative, FSGS may show IgM and C3 trapped within sclerotic segments, and MGM demonstrates granular IgG staining reflecting immune complex deposition. On electron microscopy, MCD, diffuse foot process effacement, FSGS, focal foot process effacement without immune deposits, MGM, subepithelial electron-dense immune complex deposits, the pathognomonic finding. These are some of the highest yield pathology findings in nephrology examinations. The final clue is how these diseases respond to treatment. Treatment reflects the underlying disease mechanism. MCD is highly responsive to steroids, with prednisone as the first-line treatment. FSGS responds less well because permanent glomerular scarring has already developed. Management focuses on reducing proteinuria and preserving kidney function. MGM requires treatment of the underlying cause when secondary, together with supportive therapy. The steroid response is generally poorer than in MCD. For examinations, remember this: MCD, excellent steroid response. FSGS, reduced steroid response. MGN, treat the underlying cause if secondary. Let's finish by putting everything together in one simple examination framework. When you see nephrotic syndrome questions, ask yourself 4 questions. Who is the patient? A child? Think MCD. Adult, 40 to 70 years, MGN, and any age, consider FSGS. What does the biopsy show? Normal light microscopy, MCD. Focal segmental sclerosis, FSGS. Diffuse capillary wall thickening, MGM. What does the electron microscopy show? Diffuse foot process effacement, MCD. Focal foot process effacement, FSGS. Subepithelial electron-dense deposits, MGN. How does it respond to steroids? Excellent, MCD. Reduced, FSGS. And poor, MGN. Remember these 4 questions and you'll be able to distinguish the 3 major causes of nephrotic syndrome with confidence. Age points you in the right direction, but the biopsy confirms the diagnosis. So let's put that framework into practice. A 52-year-old patient presents with nephrotic syndrome. The biopsy shows diffuse capillary wall thickening, granular IgG staining, and subepithelial electron-dense immune complex deposits. What is the most likely diagnosis? Membranous glomerulonephritis. This is the classic presentation of MGN. So let's finish with some classic high-yield facts to remember. MCD is the most common cause of nephrotic syndrome in children. MCD, normal light microscopy and diffuse foot process effacement. FSGS, focal segmental glomerulosclerosis with a reduced steroid response. And MGN, adult nephrotic syndrome with diffuse capillary wall thickening, granular IgG staining, and subepithelial electron-dense immune complex deposits. Think age, biopsy, electron microscopy, and steroid response to distinguish the 3 diseases.
Thanks so much for watching. If you enjoyed this lesson, be sure to check out our memory scenes, memory songs, and visit our website for lecture notes, illustrated slides, and high-yield exam revision study packs. If you found this video helpful, don't forget to like, subscribe, and share it with a friend or classmate.
So until next time, see it, remember it, master it.